Hello, welcome and kumusta? Thank you for joining me in this OT Conversations. This is your host, Hal. We'll just have these little wonderful conversations regarding occupational therapy, some of the things about occupational therapy, some of the little things that can improve practice. This one is intended to occupational therapists who are newly qualified, or for those students who are learning to be occupational therapists, or for those clinicians who've been a therapist for a long time and wanted to just refresh themselves with some fresh ideas, or refresh themselves with ideas that they've come across with over the years. Again, this is just an OT conversation. I have been looking at some of the episodes that I have done, and it's gone over 70 now. And I'm scrolling back, and I'm thinking, is it really true that I have not yet had the discussion about the parameters of assessment and intervention? If not, then that is the topic that I want to discuss now. We will talk about the parameters of assessment and intervention. This is very basic, and it's very simple, and it's so useful. So these are the 4 areas that you look at when you are conducting an assessment and when you're doing your treatment. So the first parameter of assessment and intervention is the parameter of independence. Straightforward, isn't it? This is the most popular thing. When you look at a person's ability, particularly with their ADLs, you are looking at their level of independence. So how do you quantify independence? You can say mild, moderate, maximum independence. That's one. The challenge with this is that in the country, in United Kingdom, people do not communicate in the levels of mild, moderate, and maximum independence. We don't do it like that. Or even if you do, say you are a therapist like myself who came from overseas, even if you're using that, people would not use it because it's just contextually not the mode of communication in terms of the levels of independence. So that's one. You measure a person's ability with independence. And you can describe it in here. Most of the time, it's more with levels of assistance. So people can do it whether they're independent or set up assist. Again, that's one that's borrowed from across the pond, set up assist or standby assist. That's again something that is borrowed. It's not commonly used, but it's something that's easier to describe. So independent, standby or set up assist. And then you have assistance of 1, assistance of 2, or special nursing care. So this is the parameter of assessment. So again, we're talking about ADLs, guys. We're not talking about performance components. We're talking about performance areas, particularly on self-care. This is all about the parameters of independence. So you can see a person, say grooming, you can just quantify the person is independent or not, or the person needs setup assist, and then they can do the grooming. You do the assessment on that parameter. Another parameter is the parameter of safety. So whenever a person is doing their ADLs and their personal care, you can measure it and you can assess it in the levels of safety. Say, for example, toilet transfers. A patient is able to transfer to toilet, but is needing standby assist because the patient is not safe. Okay, so there's 2 things now that you're adding, okay? So you now have the parameter of independence and you add in the parameter of safety. So every ADLs, you measure these things. Safety, you measure their ability, so it's level of independence. And then the next thing would be the parameter of adequacy or quality of performance. And what do we mean by this? So when you say adequacy or quality, it means their ability to perform tasks. And you describe the quality. And there are a few descriptors here. One, is there or is there not a presence of pain? The second one, can they do it with ease or with difficulty? And then the third one would be the levels of fatigue, which is and the time that it's taken them to do the things that they needed to do. So, how do we apply these parameters of adequacy and quality? For example, you are working in an adult care facility or a rehab unit. You've done the washing and dressing, and you've seen that the person was able to do it. So the person is independent. Then you find out that it's taken about a long time for the patient to be able to do it. So what you do is you practice it again because you wanted the person to be able to do it faster. Or sometimes if they're putting on their clothes, because they do not know the technique yet on how to do it, they're able to do it, but with pain. And what you want them to do is you want them to be able to dress with less pain. So that is particularly on the parameter of quality. And then another one is in terms of fatigue. For example, they were doing grooming and you provide the adaptive aid of perching stool. And the reason why you did that is because you want the person to be able to put or brush their teeth or do their grooming with ease and with less fatigue. Yes? Okay. So there you go. 3 parameters already. You have the parameter of independence, you have the parameter of safety, and you have the parameter of adequacy and quality. The next thing, which would have been one, would be the parameter of value and of importance. Sometimes you would do things because a person is asking and is aiming to do that thing that you want to do. So for example, a person comes to you and she says, I don't have any information about pendant alarm. As a therapist, all you need to do is provide them with the information regarding pendant alarm. That is the parameter of the patient really valuing that she wanted to know about pendant alarms. Simple. How would this address the problem? The first problem is the patient does not know how to get pendant alarm. And with the OT, your goal would be the patient will know how to get the pendant alarm. And then your intervention would be education and site posting. And after your intervention, the patient now knows how to get the pendant alarm. So if you make an acronym about this, it falls on the acronym called VISA: Value, Independence, Safety, and Adequacy. Straightforward. Everything that you will do with ADLs will fall on this category. Now, how are you going to apply this in practice? A practice application for this is when you are doing your goal setting. This is where it can be useful when you're setting the goals with the patient. For example, a person, say, has had a major trauma incident to a point that the person's been deconditioned, been in bed, very bad chest problem, been deconditioned for quite some time. The person is in bed and the doctor is happy for this person to be discharged home. And you're not happy because you haven't yet reached your goal. What was your goal? If your goal was the person to be independent getting out of bed, and in the end, once the person was medically optimized, the person was needing their family's help, then you've not reached your goal, haven't you? Because you aimed for independence. So what you do as a clinician is you really analyze the situation, and then at the end of it, by the time a person is discharged medically, you can estimate as to where the person would be at. And this will take some skills in terms of goal setting, because you really wouldn't know the independence or the level of ability a person is unless you've seen a lot of it. This is where experience comes in, and you will develop your ability to functionally prognosticate your patients. So if your goal was for this person at the beginning and you started that novice technique of relying on independence straight away, and you aim patient will be independent getting out of bed, or will be independent getting out of a flat bed, and then in the end, after 2 weeks of being in the hospital, the person got discharged and the person was getting help from family, then you did not achieve your goal, didn't you? But you could easily put in a goal of the person can be discharged or will be able to get out of bed with standby assist. So that's a bit conservative. So with standby assist, at least it gives you a leeway of sometimes a person will, sometimes a person will not. And again, this is a case-to-case basis depending on how you see the patient. Normally, I can see a patient and I can tell whether they're going to be independent or not. And that comes with age and clinical skills and lots of practice. So don't forget, guys, practice, practice, practice. So that is one aspect. You can set goals based on that. Now, the other goal, when you cannot guarantee independence. When you cannot guarantee independence, you can aim for the patient to be able to do things safely. And what do I mean by that? For example, a person is at risk of falls. The issue is that the person cannot access the toilet facility safely. And you can aim that before discharge, a person will be able to access the toilet facility safely. That was your goal. So how are you going to do that? You can do your retraining. You can do your restorative retraining. You can do some adaptive aids, modify interventions. And then after the period of rehabilitation with you, you felt this person is still not reaching that level of independence to be safe. And the person is still not reaching that level of safety despite the adaptive aid. So what did you do as an occupational therapist? You then used the sportive intervention, meaning you got reablement care in. Now that was your intervention. So now, after the reablement care, after the carers being put in, and with the persons and the people being there to support the patient, the outcome then would be the patient now can access the toilet facility safely. How? Because of the carers. How did the carers got there? You prescribed it. What kind of intervention would that fall under? Supportive intervention. So there you go. Safety is one thing that you can aim for. Another case scenario, for example, in terms of adequacy and quality, say you have a patient, an orthopedic patient with a shoulder replacement, and that is quite painful on the shoulder, and patients cannot move their arms. It's very painful. Again, you're not addressing the shoulder, but and here it would be the dressing. So before you coming in, what's the issue? The patient can put on clothes, but with difficulty. You can state the problem like that. Or the patient has difficulty putting on clothes. Now, if it is on the parameter of adequacy, then your goal would be the patient will be able to put on clothes with ease, or the patient will be able to put on clothes with less pain on the replaced shoulder, or the patient will know of the techniques on how to put on the clothes with less pain. So how are you going to do that? You teach the person some one-hand dressing technique. Onto the bad hand first, then onto the head, and then onto the good hand. And then taking it off, you pull it off over the head, and then pull it off the bad hand, and then lastly would be on the good hand. So one-hand dressing technique in the same way as you would when somebody has had a stroke. So when you do that, so that is a modify intervention. Type of intervention there is a modify intervention. And once you've done that modify intervention, after the session, the person is now saying, how are you? Can you do it with ease? Yes. How did you know how to do it with ease? You can ask the patient like that. The patient would say, thanks to you, you taught me how to do it. Simple, isn't it? We've talked about the setting goals and identifying problems, stating it in the parameter of independence. We've talked about stating goals in the parameter of safety, and we've spoken about setting goals in the parameter of adequacy and quality. Now, what about the parameter of value? So the parameter of value is really a strange one, but it happens. It's a phenomenon that it's just there. People ask you for something and then you give it. Why do they ask you? Because it's something that they do not have. So it's something that they want to have. Again, most of the time, it's information. Say, for example, you come in and you educate the family about the nature of their next of kin's condition. So what's the problem? The family does not know the next of kin's condition. So it's awareness. And then your objective would be family will know. And then when you say family will know, how did you do it? You did the education. After the education, what's the outcome? Now the family knows. Very simple. If, for example, the patient does not know how to utilize a CPAP machine or an NIV machine, non-invasive ventilator, or BiPAP machine. So patient does not know how to operate the BiVAD machine. And then the patient will know how to operate the BiVAD machine. And then you teach them. That's a simple matter of knowing, and that is a simple matter of value. Equally, you can restate that in a sense where, in a matter of independence, so a patient needs assistance putting on or operating the NIV or the BiPAP machine. And then your objective would be the patient will be independent operating the BiPAP machine. If you think that they can do it, then yes, you can do the retraining, you can do the education. But if, for example, you know for a fact that the patient is not capable or will not be capable of using the BiPAP machine or putting the mask on and turning it on because of some condition, say Guillain-Barré syndrome or Guillain-Barré syndrome, then you know for a fact that they're not going to be independent, but you can make it safe. So the patient, say Guillain-Barré syndrome or motor neuron disease, they cannot put these things on, severe motor problems. And then you just do it and you teach the carers on how to do it. And then the outcome would be patient will be safe putting on the BiPAP machine. Those are the parameters of assessment and intervention. Now, I'm not making this up, guys. This you will find in the textbook of Occupational Therapy by Willard and Spackman. So that is the Bible of occupational therapy. In case your university has not taught you that it is. It's there. It's gone many editions, but these by Willard and Spackman are the two first educators or the first few OTs. And they have come up with this book, and it's Willard and Spackman's, and it's gone, I don't know, 13th edition now. Now, I am not making this up. I just could not pinpoint which chapter it is in. It's there. What I'm doing now is I am supplementing you with some practical applications of what you would find in that book. Now, for those of you who's already in practice and have encountered quite a few things, there is this standardized evaluation tool that's used in Canada, and it is, again, the tool of the model itself. It's called the Canadian Occupational Performance Measure, which is the one that is supported by the Canadian model of occupational performance model, right? Canadians, they're amazing because OTs, they have their own national model, Canadian model of occupational performance. And then their tool is Canadian Occupational Performance Measure. And when you look at these Canadian Occupational Performance Measure, the tool and the definition is this. How to use it would be like this. First, when you encounter a patient, you would ask them of the ADL activities that they have difficulty with. So a patient would list it down. So already, patient would be stating things in a client-centered manner and an ADL occupation-based manner because you're already targeting the ADLs. They'll state in all of the things. For example, I have difficulty getting out of bed. I can't go to the toilet. I can't wipe my bottom. I cannot walk. I cannot brush my teeth. So all of those things, you write that down. And then the next thing that a therapist would do is would ask a patient to put a score in terms of importance and put a value in their importance. So from 1 to 10, 10 being very important and 0 is not important at all, what's the score? If the patient says, okay, for getting out of bed, that is 8. Brushing my teeth, that'd be 5. Doing the showering, that would be 7. So by knowing those things, it can help you prioritize things for your patients already. So that's good because it's very direct and it's very patient-centered. Then the next thing that you'll be asked is you ask the person to put a score on their performance ability. Again, 10 being very good and 0 or 1 not good at all. Performance is 1. They will put a level of their independence and their performance, yeah? Again, that is the parameter of independence. The next thing is how satisfied are you with your ability, okay? And you put a score. And the satisfaction will fall on the category of adequacy. Because if a person is doing it with difficulty, then they won't be too satisfied, won't they? It's amazing. It's smart. It's so smart. And then if it's with pain, then they won't be too satisfied. So how satisfied are you? Actually, that's the last one. The other one where a person would be asked is mark your safety score on those areas that they've identified. 10 being safe and 0 not safe at all. So you see, in the Canadian Occupational Performance Measure, it is checking for value, the areas. It's getting the patients to prioritize the ADL areas. The independence, put a score on their performance. Safety, how safe they feel they are when they're doing the task. And last would be their satisfaction, which is the quality. All right. There you go, guys. Very simple. Value, independence, safety, and adequacy. And adequacy would fall on the pain, the fatigue level, and the rate of performance. Those are the 3 things that we assess for ADLs. So when it can help you when you're prioritizing the problems, it can help you when you are setting the goals. So you're not just setting the goals based on level of independence. Okay, there are other areas. So that's why with occupational therapists, we can always get things done, because we may not be able to get the person independent, but we can sure get them safe, or we can make it easy for them. We may not need to retrain them, but we can actually support them. Now, again, what I'm saying about the catchphrase that I have, anything you do matters and has an outcome, because you'll always get it right. Okay, guys, I hope you learned a little something today. If you enjoyed the conversation, pass it on to your friends, talk about it, grow together. Until next time, bye.
If you enjoyed this podcast, talk to your friends and colleagues about it. Like it, subscribe, share, and do what you can to appease whatever algorithm that is at play. Just remember, guys, anything you do matters and has an outcome. Until next time, bye.